Okay, I think that it's time to start. Good morning, everybody, and welcome to this, I think, very exciting session entitled Physical Activity, the All Day Matters. First of all, I want to introduce myself. I'm Andrea Molao. I'm a sport and exercise medicine physician from Padua University, and I want to thank the organizing committee for inviting me. And it's really a pleasure to be in this wonderful place and also very, very interesting conference. I ask my co-chair to introduce themselves. So please, Dave.
I'm Dale Bond. I'm from Hartford Hospital, and I'm a researcher in physical activity promotion, particularly in the context of metabolic and bariatric surgery.
I am Regiane, and I live in Brazil, and I work in University Hospital, and I research about exercise and bariatric surgery patients.
Okay, so before introducing the first speaker, I just want to make a short forward to get into the topic. And this is because despite all the improvement we obtained with both the pharmacological therapy and the bariatric surgery, physical activity still maintains its fundamental role in the prevention and treatment of obesity and metabolic disorders. And this is not about just weight loss. We know that physical activity is not really strong. It's not really enough to have a important weight loss for our patient, but it's about the prevention and the treatment of comorbidities, as well as we know that the level of physical activity is important to reduce the cardiovascular and mortality risk. And by the way, what we are observing in recent researches is that when we measure really not just keep the level of physical activity by questionnaire, but we measure the number of steps per day, we observe that physical activity is a really strong predictor of risk and can really reduce the risk. A recent paper, just to remind you, demonstrated that 1,000 steps per day, increasing 1,000 steps per day, reduce the all-cause mortality by 15%, and an increment of 500 steps per day reduce the cardiovascular mortality by 7%. But we also know that it's not about the physical activity, but also the overall physical activity amount and pattern during the day, and the 24-hour activity and inactivity behavior that are important, play an important role, and we are going to see this in the next presentations. By the way, what is also, I think, very interesting and quite new is also that how activity times over 24 hours interact also with our individual preferences for sleeping and eating, identify different chronotypes and risk profiles. And also about this, we are going to have a really intriguing presentation. Finally, coming back to the exercise and moving from theory to practice, there is still so much to understand about what is the most effective way to improve adherence to physical activity and exercise guidelines. So supervised exercise or unsupervised exercise, general counseling or personalized prescription, there's something still a question still open. And the last speaker will talk about the supervised exercise. So let's start with the first speaker, Dale.
So I'm very pleased to introduce our first speaker, Dr. Aurélie Bayou. She's an associate professor at the University of Quebec in Canada, and she'll be talking about what are 24-hour movement guidelines, background, and rationale.
Thank you. Thank you for the introduction. I'm really happy to be here and have the opportunity to speak about the 24 movement guideline, especially because the first 24-hour movement guidelines come from Canada, and I'm a Canadian, so that is the reason. And I have no potential conflict of interest to declare, except maybe that I am Canadian. So up to you if you think that is a conflict of interest. So, from a movement perspective, a 24 period is divided in sleep, sedentary time, moderate vigorous physical activity, and light physical activity. It involves a continuum of movement progressing from no movement, as such, from example, sleep, and more intensive movement, like vigorous exercise. Over the last decades, there is a lot of study that reported the benefits of moderate vigorous physical activity, low sedentary behavior, and adequate sleep on health, mobility, and mortality in adults or children. And more recently, light physical activity have also shown some benefits on health, but until recently, movement behavior have been examined in isolation with no integrated approach. Usually study assess only physical activity or sometimes physical activity and sleep, but they don't have an integrated approach. But it's easy to understand that a change in the amount of time spent in any one of these behavior will change the amount of time spent in another behavior. For example, the benefits of physical activity are not the same if the activity is done at the expense of sleep or at the expense of sedentary behavior. Based on these facts, a new integrated movement behavior paradigm emerged, and the whole-day measure concept has seen growing interest among researchers and public health authorities. And with the growing interest in researchers, Tremblay and collaborators develop a more complex 24-period model of movement. I say complex, but it's really not complex, especially if you see some presentation with hormonal pathway that is really more complex. But here, in this model, you can see in the middle the main behavior category using energy expenditure with sleep, physical activity, and sedentary behavior. And after you have the general category using posture. For example, for physical activity, you have standing, sitting, recycling, and lying, and other. At the same time, there is more and more research about the 24 movement guideline, model, and Rollo and collaborator made a systematic review on this topic, and they conclude that the whole 24 time use is associated with a health indicator in children and adults. More exactly, what they've found as evidence is that there is significant association between the composition of the 24 movement behaviors and indicator of adiposity and bones, health among preschoolers, quality of life among children, adiposity, fitness, and cardiometabolic, social, and emotional health among children and youth, cardiometabolic health in adults, and adiposity and fitness among older and adults, and also mental health and risk of mortality among older adults. So that is important to understand that there is association with the composition and 24 movement behavior and health, but also with the fact to reach the new guideline, 24 movement guideline behaviors and health. And also study reported that there is a dose-response relationship that is better to reach the 3 behavior movement guidelines that are recommended rather than 2 or 1 and 0 behavior recommended by guideline. So based on this new paradigm and the evidence, 24 movement guidelines were developed, and it aimed to provide guidance for professionals, researchers, decision makers, and population. It aimed also to establish measurable targets for surveillance, allowing to make some comparison, and also to inform the development of program and policy to promote healthy movement behaviors, not only physical activity, it's larger than just physical activity. So as I said at the beginning of my presentation, the first 24 movement guidelines come from Canada, and it was in 2016 in youth and children, and after in 2017 we have guideline for children between 0 to 5 years, and in adults it was in 2020. With this new guideline, there is an international impact. Now we can see other guidelines that emerge. For example, in Australia and New Zealand, we have guidelines for physical activities, sleep, and sedentary time for children and youth, but also we have guidelines in South Africa for birth to 5 years. The World Health Organization also developed guidelines in 2019 based on the same paradigm for children under 5 years old. In my knowledge, there is no currently guidelines in adults in other countries than Canada, but I know that is coming soon in other countries, like for example in Australia. So what are these guidelines? I speak about the guidelines, but what we can see in guidelines. So for the children and youth, I know that probably you don't have children in your practice if you work in bariatric surgery, but maybe you can work with youth. So the recommendations are SWIT, step, sleep, and sit, the 4S. And SWIT is about to reach 60 minutes per day of moderate vigorous physical activity. STEP is several hours of variety of structured and unstructured light physical activity. Sleep is what is recommended as a good quality sleep between 9 to 11 hours and between 8 to 10 hours for teenagers. And sit is no more than 2 hours per day of recreational screen time. And it's in use, usually this recommendation is not reached, and limiting time expand period. For adults, what are guideline recommendation in Canada? It's physical activity, sleep, and sedentary behavior. For physical activity, that is the famous recommended 150 minutes per week of moderate to vigorous physical activity, with muscle strengthening twice a week, and also do light physical activity as much as you can, several hours. For sleep, it's between 7 to 9 hours of good quality sleep. Good quality is very important because there is like the quantity, but the quality, of course, is really important. And for sedentary time, limiting sedentary time to 8 hours per day or less. And also no more than 3 hours of recursion screen time. And what also is recommending is to break a long period of sitting. So if you want to get up during my presentation, you can move. It's recommended. So, and finally, we have also an adaptation for older adults, and that is quite the same recommendation, except that they had like physical activities that challenge balance, and the sleep time is between 7 to 8 hours inside of 7 to 9 hours. So now I present you the guideline. What is also interesting for researcher and policymaker or as provider is the prevalence of people that reach this recommendation, and especially in people with severe obesity. And when I did this work, we don't have data. So I work with Jean-Philippe Chaput on a national representative cohort of Canadian adults to know if these adults reach recommendation, and we make this comparison according to body mass index. And I don't know if I don't. Is it work? So if you look at there is only 90.5% of adults that reach all three recommended behavior movement in normal weight. And so what we can say is that there is really a few number of adults reaching this recommendation, especially if you look in obesity class 1 or obesity class 2 and 3. In this paper, we also make some association with the health. And what we found is that there is beneficial association between the 24 guidelines recommendation and health indicator among all BMI classes. And we concluded that all adults benefit from meeting the 24 guidelines regardless of weight status. When we look at the 24 movement continuum and bariatric surgery, there is, to my knowledge, only one study that assesses the whole day, because we have paper on physical activity or sleep, but we don't have with the 3 behavior. And this paper, they conclude that no movement behavior improved after bariatric surgery, and that an increase in moderate vigorous physical activity may increase weight loss regardless of movement. It's important to understand that this may increase because, as we suggest, the last talk we see, and according to evidence in experimental study, we know that physical activity have not a major impact on weight loss. And if you want to know more about the 24 movement continuum and bariatric surgery, you can come tomorrow and see the presentation of Dale and Dale Brown and Lee Schumacher. And we provide new evidence and new data on the 24 movement continuum and bariatric surgery. So in the systematic review of Rollo, they also provide future duration because that is a new paradigm. There is more and more study, but to really need more now, more good quality longitudinal and interventional studies. We also need to use validate and reliable data or measurement. We have accelerometer, but we know with accelerometer there is no optimal option. Sometimes an accelerometer is better to measure sleep, another time another accelerometer is better to measure physical activity. So we need to work on that. We have a lot of data in youth and children, but data in adults, and especially in clinical and at-risk population, are missing. We need also data to make comparison between countries and to understand potential moderator and mediators. And even if we have a lot of data in kids, in children and youth, we don't know the potential family, school, community, and environment predictor of 24 guidelines adherence. I really like also this paper that is a consensus, and I recommend you to read it. And what they say about the 24 movement guideline analysis approach, they agree that there is more investigation that we need to do because of the codependency between the different behavior. And this codependency also is important to consider when we are doing guidelines. And also, in the second point, they reported that we need more study in light physical activity because there is more and more evidence that light physical activity can have some potential benefits, for example, for mood and other mental health outcome. And at the end, they conclude that there is no gold standard able to test what is a better approach to consider whole the day. And currently, the best solution is probably to have a lot of evidence and with different kind of analysis, statistical analysis. So to conclude about the 24 movement guidelines, sleep, sedentary behavior, and physical activity all interact together to impact health. Adherence rate to the 40-hour movement guidelines are low, especially for moderate vigorous physical activity and sedentary time in adults and also in youth. New 24 movement guidelines around the world. We have more and more guidelines with this new paradigm. And the work now is about implementation. I know that in Canada we have a team with this expertise, and I think it's really important to work that the health providers and population know these new guidelines, and that is not only physical activities that is important. The other movements are important for health. And also, we need additional research to support the 24 movement guidelines rationale. That is important. So thank you very much for your attention.
Thank you, Dr. Bayou. So now we'll have the UK perspective on the 24-hour movement behaviors, and this will be delivered by Dr. Louisa Herring. She's the lead research associate for physical activity research and implementation at the University Hospitals of Leicester. And she'll be speaking on 24-hour movement behaviors, obesity, and cardiometabolic risk. Thank you.
Thank you very much. Thank you for inviting me to speak today on the 24-hour movement behaviours and obesity and cardiometabolic risk. So, an area of our research in the lifestyle team at the Leicester Diabetes Centre in the United Kingdom looks at linking cardiometabolic disease health outcomes to the 24-hour movement behaviours. And as you've just heard, the 24-hour movement behaviours is becoming more and more of interest nationally and internationally and incorporated into guidance. So the Canadian guidelines were the first to be developed and for the general population, regardless of disease. And we were really pleased to develop the physical activity guidelines for the EASD ADA consensus guidelines for type 2 diabetes. So the lifestyle team at the Diabetes Centre came up with the concept of the 5 S's. These 5 S's are sitting, stepping, sleeping, sweating, and strengthening. So as you can see in the table here, we've got the physical activity guidelines, and the 5 S's, the 24-hour physical activity behaviours for type 2 diabetes, and the impact of these physical behaviours on cardiometabolic health in people with type 2 diabetes. The direction of the arrows show the level of improvement, and the colour of the arrows shows the strength of the evidence. And for the rest of the presentation, I am going to use the concept of the 5 S's for obesity and cardiometabolic health outcomes. So, first of all, sleep. So when we think about sleep, we usually think about 3 elements: quantity, quality, and chronotype. So individuals should aim for consistent, uninterrupted sleep, even on weekends. And the short durations of sleep negatively impact obesity risk. Less research exists for longer sleep durations. We know that poor sleep is associated with a higher BMI, and severe obesity is associated with significant sleep disturbances, resulting in sleep debt, which negatively affects physical activity and appetite. And research suggests that even in chronotypes, so those who go to sleep late and wake up late, are less successful in adapting to weight loss treatments and long-term weight control. And research also suggests that bariatric surgery-induced weight loss is less effective in even chronotypes. So as you can see here in this figure, for every hour slept less than 7 hours, there's an increased relative risk of obesity. And sleep extension intervention studies have shown that between group differences, a between group difference in change from baseline in energy intake of 270 calories. Sitting. So individuals should limit sitting. The time spent sedentary is adversely associated with cardiometabolic health, with detrimental effects on obesity. We should break up prolonged sitting every 30 minutes with short, regular breaks of slow walking. Simple resistance exercise is also positively associated with measures of adiposity, waist circumference, and BMI in particular. And time spent sedentary may be a more important indicator of poor health than moderate to vigorous physical activity. And as you can see here, the association between sedentary time and mortality. For individuals who spend more than 9.5 hours sedentary, the risk of all-cause mortality increases significantly. And research that we've undertaken at the Leicester Diabetes Centre looks at the association between sedentary breaks and adiposity. Less daily breaks in sedentary time is associated with a higher BMI and a higher waist circumference in obesity. So even after accounting for time spent in moderate to vigorous physical activity, these are the distinct risk factors associated with sedentary time. Here's an example of a protocol that we use to look at sedentary breaks and obesity-related metabolic outcomes. You can see here that postprandial glucose and insulin decreases when sitting is interrupted with light physical activity. This is greater in individuals with a higher BMI, females, and individuals of South Asian ethnicity. So when we look at stepping, individuals should aim for an increase of 500 steps, as this is associated with a 2 to 9% decrease in risk of cardiovascular morbidity and all-cause mortality. And as little as a 5 to 6 minute brisk walk per day can equate to a 4-year greater life expectancy. All of you have probably heard about the 10,000 steps per day threshold. And in fact, little research actually exists around this. So this study looks at the risk of all-cause mortality in individuals above and below 60 years of age. And you can see here the optimal amount of steps for these two age groups. And there is relatively little benefit for anything greater than this. So stepping and metabolic bariatric surgery. So this study showed that before surgery, individuals were undertaking 7,600 steps per day. Steps increased by 1,200 at 1 year, and this change remained at 3 years. And a systematic review that I undertook showed that moderate to vigorous physical activity decreased 3 to 6 months post-surgery, and whilst step count increased 3 to 6 months post-surgery, implying that more lower intensity physical activity is undertaken within the first 6 months of surgery. So we should pick up the pace. If you can change a 14-minute walk to a 7-minute brisk walk, there's an additional 14% reduction in the risk of cardiovascular disease. And when we look at individuals who walk 4 miles per hour versus those that walk under 3 miles per hour, the individuals that walk above 4 miles per hour, biologically, their age is 16 years younger. So walk fast, die older. Sweating. So the recommendations for moderate to vigorous physical activity varies depending on the individual's weight or health-related goal. So we will all be aware of the 150 minutes of moderate to vigorous physical activity for maintaining and improving health. There's been suggestions that 200 to 300 minutes per week to prevent weight gain after weight loss, and research even suggests that 420 minutes of moderate to vigorous physical activity is required to promote clinically significant weight loss. Moderate to vigorous physical activity should be supplemented with 2 to 3 resistance exercises per week and flexibility and balance in older adults. So when we think about these thresholds and individuals after bariatric surgery in particular, most of them don't meet the 150 minutes of moderate to vigorous physical activity per week. So something is always better than nothing. So looking at moderate to vigorous physical activity and bariatric surgery outcomes, if we say that more lower intensity physical activity is undertaken in the first 6 months of surgery, and patients are no less sedentary following bariatric surgery, recent research has showed low improvements, although non-significant, and a lifestyle intervention that looked at diet and moderate to vigorous physical activity initiated in the first 3 to 6 months post-surgery saw no effect on weight loss, sedentary behaviour levels, physical function, physical activity or quality of life. And an exercise intervention that our team undertook at the point of weight regain, at the point of weight plateau, we increased moderate to vigorous physical activity and saw a significant improvement in physical function and a significant difference between the control group and the intervention group of 5.6 kilograms, implying that moderate to vigorous physical activity can support with weight loss maintenance. I just wanted to show this slide because pharmacotherapy is becoming more popular in obesity management. So this study looked at a very low-calorie diet and then randomized individuals to either the placebo, exercise alone, pharmacotherapy alone, or exercise and pharmacotherapy. And as you can see, the red line on the figures showed significantly greater improvements in both change in body weight and change in body fat percentage, and this was a combination of exercise and pharmacotherapy. And it's important to note that in the United Kingdom, we currently only license pharmacotherapy for weight loss for 2 years, so exercise could be an important adjunct at the point at which pharmacotherapy is stopped. Strengthening. So resistance exercise can minimize muscle and bone mass loss during weight loss, improve glucose and insulin sensitivity. Resistance exercise is important to help prevent frailty, commonly linked to both obesity and weight loss in older adults. And adulthood obesity increases the likelihood of frailty and pre-frailty in older adults by 2.5 times. Routine assessment of BMI and waist circumference could identify and lower this frailty risk. So as you can see in this table, weight loss without exercise may limit long-term benefits, leaving individuals at an increased risk of poor physical function and frailty. Functional improvements were greater with aerobic and resistance training than with either modality alone. Weight loss plus combined aerobic and resistance exercise is the most effective in improving functional state of obese older adults. I just thought I'd show you some data from the Codex study. So we recruited 800 individuals with a BMI on average 31. These individuals did have type 2 diabetes and they underwent physical function tests. We identified 30% with impaired physical function, and this 30%, when looking at the hand grip strength, had an age above 20 years older than their chronological age. And when we looked at the sit-to-stand test, these individuals, bearing in mind on average their age was 64, their age on their sit-to-stand test was above 90 years. So physical activity expertise is needed in routine weight management services, particularly in the United Kingdom. Objectively measured 24-hour physical behaviours are important in routine weight management. We need to obtain physical activity and sleep measurements, quantifiable physical behaviours to be able to enable us to provide a personalised care pathway for each individual patient. And within the lifestyle team at the Leicester Diabetes Centre, we have a translational pathway for our physical activity research. So from hypothesis generation to population and patient benefit, which leads me on to the tools that we are currently developing. So Steps for Health is a physical activity web application for people living with or at risk of long-term conditions. This tool is designed to help people self-manage their physical activity levels using objectively measured data around the 5 S's concept. It makes specific ability and mobility specific goals for those individuals. And another tool that we've developed is the Physical Activity and Health Metrics Dashboard to be able to help facilitate a conversation between a healthcare professional and the patient in the clinic. This is also designed based on objectively measured physical activity levels around the 5 S's along with their health condition. So the patient and the healthcare professional can have a discussion and make shared decisions around what to improve and what people's priorities are. So in conclusion, the 5 S's, it appears an essential concept for improving obesity and cardiometabolic health outcomes. However, much more research is needed, and specifically in the area of metabolic and bariatric surgery. Thank you very much.
And now I will be very grateful if you would help me to welcome to the stage Professor Giovanna Muscogiuri. She is an assistant professor in endocrinology at the University of Naples, Federico II, and she's also professor of medicine at Tucson University, Arizona. We could say that she's the lander here because she's from Naples. And the title of her presentation is Role of Chronotype in Physical Activity, Sedentary Behavior, and Sleep among Individuals with Obesity. Thanks.
Good morning. Thanks, Chair, for the introduction. So, chronotype is the subject's attitude that determines individual circadian preference in behavioral and biological rhythms related to the external light cycle. So, subjects with the evening chronotype, that means that subjects that are more prone to carry out most of their daily activities in the second half of the day, have been reported to be at high risk of developing obesity. And this was mostly due to the tendency of these subjects to follow an healthy lifestyle, but also they usually experience sleep disturbances, are affected by an impairment of cortisol secretion, so they usually have a reduction of peak upon waking time, an increased concentration later in the morning until lunchtime, and an increased cortisol secretion during the whole day. But we also know that subjects with the evening chronotype are characterized by a reduction of melatonin levels that is usually accompanied by a reduction of antioxidant and anti-inflammatory properties. But there are also genetic and epigenetic factors that usually predispose these subjects to be all subjects. And all these features are able to predispose these subjects to develop obesity and, of course, obesity-related complications, and in particular, cancer. So let's see the study where it was investigated the role of chronotype and age on seasonality. We know that seasonality refers to season-dependent fluctuation in sleep length, social activity, mood, weight, appetite, and energy level. So the study was carried out in 410 participants, and according to a path analysis, chronotype and age predict propensity for seasonality. But also we know that sleep problems were mostly related to chronotype, but not to age. Also, older adults in the study seem to be more resistant to seasonal changes compared to young and middle-aged adults. This study was carried out in 63 female university students that underwent a stress test and underwent two questionnaires in order to investigate chronotype categories and the presence of sleep disturbance by Pittsburgh Sleep Index. And the results of the studies highlight that evening types reported lower subjective sleep quality and longer sleep latency than morning types. In addition, evening types reported higher self-perceived stress after stress test than morning types. But also we know that chronotype could have an impact on exercise timing. And in particular, this study that was conducted in college students in New Jersey reported that evening chronotypes referred poorer sleep quality, but also greater daytime dysfunction and less positive affect compared to morning or neither chronotypes. So, since subjects with evening chronotypes used to be affected by sleep disturbances, we know that sleep disturbances could be also an additional mechanism that predispose subjects with evening chronotype to develop obesity. And in fact, we know that both sleep disturbances and obesity are tightly related, although we still don't know who comes first. There are several mechanisms that connect obesity with sleep disorders and vice versa. We know that subjects with sleep disturbances usually have an increased secretion of cortisol because they have a high level of stress, but also an increase of ghrelin, leptin, that is usually accompanied by leptin resistance in obesity, and also reduction of melatonin. And we know that melatonin is very important in the context of metabolic field because of its insulin sensitizer properties. So we also know that chronotype change over the life stage. And we know also that menopause is a life stage that is usually accompanied by an increased cardiometabolic risk. So in menopause, there are several hormonal changes. These several hormonal changes and there is also changes in body composition with an increase of visceral adipose tissue and a reduction of subcutaneous adipose tissue. And of course, all these changes are accompanied by an increased cardiometabolic risk. We investigated the change of chronotype that usually occur in menopause, and we found that menopause was accompanied by a switch of chronotype, usually from evening chronotype to morning chronotype. Morning chronotype are the subjects that are more prone to carry out most of their daily activities in the first half of the day. So we hypothesized that this was like a sort of protective mechanism that the body is able to set in order to counteract the increased menopause-related cardiometabolic risk. But we also know that chronotype could have an effect on physical activity. And here I report the results of a systematic review that revised 23 studies on this topic. And evening chronotype is usually associated with less physical activity and more time and sedentary activities. And it occurs independently of the instruments used to collect information about chronotype and physical activity. This was a study that I carried out with my research team. The study was carried out in Naples in 172 participants during a campaign of obesity prevention. Obesity was present in most of the enrolled subjects. And as you can see here, physical activity was mostly reported by subjects with morning chronotype, while it was low prevalent in subjects with evening chronotype. Also, we investigated the association of chronotype score with circulating TMAO, that is a parameter that gives us information on microbiota. And we found also that physical activity was less prevalent in evening chronotype. We also know that polycystic ovary syndrome is a condition that is characterized by high cardiometabolic risk. And we hypothesized in this study that chronotype, and in particular evening chronotype, could play a role in determining this increased cardiometabolic risk. And in fact, we found that women with PCOS that had evening chronotypes were at higher risk of developing cardiometabolic risk, and also they referred to be prevalent sedentary instead of morning chronotypes. Also, it was confirmed in another study that I carried out with my research team in subjects with gastroenteropancreatic neuroendocrine tumors, where we found that subjects with evening chronotypes usually developed a more severe type of cancer, but also subjects with cancer and evening chronotype reported to be less active compared to subjects with morning chronotype. So evening chronotype is associated with a tendency to be less active, but also this study that was carried out in 153 volunteers highlighted another important concept. So if you are evening chronotype, you have an increased risk to drop out physical activity compared to subjects with morning chronotype. So being evening chronotype means less physical activity and an increased risk of dropout physical activity if you are doing physical activity. So we have previously told that subjects with evening chronotype usually experience sleep disturbances. And maybe sleep disturbances could be an additional mechanism that could explain the propension of these subjects to do less physical activity compared to the other chronotype categories. We know also that physical activity could have a positive impact on sleep quality, increase GH, but also improve insulin resistance, and also has a beneficial effect on mood, thus favoring a physiological sleep time. But also we know that sleep loss, both acute and chronic, could have first a detrimental hormonal impact, could increase low-grade inflammation, thus reducing physical performance, thus reducing recovery, and if there are any, could increase the risk of developing the exercise-related side effects. So, what can we do if we are faced with an hole? We set up a sort of a practical nutritional guide that we called the clock diet to manage obesity through chrononutrition. So we hypothesized that changing the food pattern of subjects with evening chronotype, using the properties of some food. In particular, we know that some food are rich in tryptophan. Tryptophan is usually a substrate for the production of serotonin, that is happiness hormone, and melatonin. So, if we encourage these subjects to eat foods rich in tryptophan at dinner, we can promote the secretion of melatonin, thus inducing a physiological sleep time and the improvement of sleep quality. We also recommend to do not skip breakfast, prefer a balanced breakfast and lunch composed of carbohydrates, fiber, proteins, and the right amount of fat. Take an adequate protein intake, especially preferring whey proteins, and take most of the daily carbohydrates intake in the first half of the day. Reduce calorie intake, and especially carbohydrates intake in the evening, and eat food rich in tryptophan at dinner. So my take-home messages are the following. Evening chronotypes promotes sleep disorders and low physical activity. Chronotype sleep quality and physical activity levels are interconnected in favoring the development of obesity. New chrono approaches could improve lifestyle habits, sleep quality and physical activity, and ultimately improve the treatment of obesity. Thank you for your attention.
Thank you, Giovanna. And we can go to the last speaker. She's Professor Regine Marcon from Brazil, Universidade Federal do Rio Grande do Sul. Professor Marcon is physical educator at the Hospital de Clínicas de Porto Alegre. She's also president of the Physical Health and Rehabilitation Nucleus of the Brazilian Society of Bariatric and Metabolic Surgery. She will talk about supervised exercise, how and why. Please.
Good morning. Thank you. I want to thank the invitation. And so, supervised exercise, how and why? I have no potential conflict of interest. And we speak about the prescription exercise in bariatric surgery patients. You need to think in these patients, the exercise promotes benefits to all patients, but you have patients in preoperative and the patients in post-operative. And these patients have different realities and economic situation, different levels of education and levels of obesity. The access to information and the access to physical activity centers are different too. And we attend patients in private and public health system. And these patients take care and are different. Specific in pre-operative, these patients, you know that these individuals with reduced cardiorespiratory function, the osteomuscular limitations, low-level physical activities, and low adherence to exercise programs. I should review the literature about prescription exercise and in pre-operative. In years 2013 up to 2018, and I found legible articles, 21 articles, and about that dealt in strength training, 9 articles. These articles, in 6 articles, the interventions were multidisciplinary. In just 3 articles, the intervention was only exercise. And these all studies had the same research group and the same exercise protocol. And summary the results in these articles, the individuals that practice exercise improved anthropometric and cardiometabolic parameters and decreased psychiatric disease. Increased maximum dynamic and maximum isometric strength. And dealt about aerobic exercise, I found 8 articles in this period. These articles, 7, the interventions were multidisciplinary or counseling, just counseling. In just 1 article, the intervention was only exercise. And results in these articles, the exercise improvement the anthropometric parameters and increase the time in daily to moderate to vigorous physical activity, increase the daily intervals equal or 10 minutes, the number of steps per day, the general health scales, the physical function, and increase the adherence and motivation for physical activity practice. And 4 articles tell about concurrent training. Concurrent training is when you have aerobic exercise and strength exercise in same session exercise. And all interventions, in all articles, the interventions were multidisciplinary, and the results is similar to other trainings. What is important is that online and face-to-face interventions did not show difference in quality of life and psychological barrier to the practice the physical activity. And the frequency in exercise sessions was higher in online activities. Maybe this is a good strategy and for prescribed exercise in this population. And what is important of preoperative levels of physical activity and the results of bariatric surgery. You know that reduced cardiorespiratory fitness is associated with a longer operation and intubation time, estimated blood loss during the surgery, and more frequent cardiovascular complications. And several factors are associated with more minutes of moderate to vigorous physical activity and 10,000 steps per day in postoperative, such as increasing exercise as a weight loss strategy, performing 150 minutes per week, reducing pain, starting physical activity 6 months before the surgery. And these improvements are observed in different interventions and different exercise protocols. And you know, the bariatric surgery promotes substantial weight loss, but promotes substantial loss of muscle mass. And the exercise in this moment for these patients promote different benefits, not just energy expenditure. The exercise post-bariatric surgery promote maintenance and or increase of lean mass, improves physical fitness, metabolic health, quality of life, and leads to additional weight and body fat loss, and promotes greater weight loss in 12 and 24 months after bariatric surgery, moment important after bariatric surgery. And in this meta-analysis, when compare the exercise groups and control groups, look, the exercise groups reduce the body weight, reduce the fat mass, and maintains or increase the lean body mass, and improve the function capacity, look the walking test distance, and the oxygen consumption maximum, and increase the muscle strength after bariatric, post-bariatric surgery. And now I speak about my work in Brazil. In this work, in this research, we've investigated the effect of exercise program with and without cognitive behavioral therapy compared by control group in preoperative patients. We randomized in 3 groups. One group performed exercise, the exercise protocol. Other group, the same exercise protocol, more cognitive behavioral therapy, and the other group, the routine treatment. In the exercise protocol in this research, the patients perform 20 minutes the aerobic exercise, more 5 minutes the strength exercise, twice a week during 5 months, and we were encouraged to increase the exercise daily. And I show same results. Look, the patients that perform the exercise increase the distance in 6-minute walk test, and in control group reduce this and increase the oxygen consumption too. And resting heart rate and the heart rate after exercise reduced in exercise groups and increase in control groups. And similar, the lipid profile increase, the improvement this lipid profile, decrease glucose in these patients, the exercise. And the weight reduce in groups that perform exercise and increase. So it's a simple interventions, and these interventions positively influenced the patient's health. And this is important. In just 5 months, the patients that don't practice exercise increase severity of comorbidities, assessed, and cardiovascular risks. It's important to treat these patients before surgery. And based in this work and all the other research, I create my program in Brazil. I attend patients before and after bariatric surgery. The name of the program is Peso 3. Peso 3 is a supervised exercise program for obesity 3, level 3. I attend these patients face-to-face and online. And this work I developed in a public health system in Brazil. And I follow more 600 patients and attend more or less 50 patients per session, exercise sessions in different scenarios and different conditions, level obesity in the moment these patients. During the pandemic, this was a good strategy to attend these patients. I changed this work because before I just attended face-to-face, but during the pandemic I need to change this work, and today I attend face-to-face and online. The patients have a low cognitive condition, normally patients poor, and I am a good strategist. We create WhatsApp groups. In these groups, I send information, and these groups for socialization and education these patients. I create one YouTube channel when I have videos about exercise and food, and the psychologist help me to different videos. This is the channel. We teach the patients to prepare the food in hospital, in kitchen, and we create e-books of recipes. These recipes submit by patients, and I work together with the pedagogy and the nutrition students, and create this together the patients. This is one e-book. And in conclusion, the recommendation is take into account individual preference for prescribing exercise. This is important. I look my patients and prescribe exercise. Is important the information, but is information when you associate the strategies. Create strategies that facilitate and involve the individual in the exercise program. This is important. Important for adherence, important to follow these patients. And exercise supervision by experienced exercise specialists increase adherence and reduce the risk that can be posed by physical activity. And I speak and I spoke and I speak now that is important. The exercise in preoperative period of bariatric surgery increase adherence and postoperative benefits. And finally, maybe the world can come together and teach each other. We are here and discussing adherence, motivation, strategies, and exercise prescription in bariatric surgery individuals is essential. And to change lives, we need to change behavioral, and physical exercise is part of this process. So you need to make patients aware of the importance of regular exercise and assist them in discovering their physical abilities, because these patients know their abilities all day. And you need to show this important practice exercise and change their lives. This is my students in Brazil, and this is the hospital when I work. And thank you, grazie a Italiani per la recezione della sua bellissima città. Grazie.
Thank you, Professor Marcon. We have a little more than 50 minutes for the discussion. Discussion is open. Someone that, okay, please. Oh, okay, yeah, we can call on stage the speakers, if they can come here. You can leave or just move.
Okay, thank you very much for this very successful session. It's really inspiring, and I would like to ask Dr. Muscuri, if I pronounce it right, about the chronotype and the timing for the performance of the exercise that you have advised your patients. For example, if there is the owl, as you have stated, or the evening type. Is it proper to advise this patient to this kind of person to perform the exercise in the evening just few hours before sleeping, for example, from 4 to 8, putting in account the hormones that would be evolved to keep them awake? So what type of recommendation would you give this person? Thank you.
Thank you for your question. The time of recommendation is usually in the first half of the day, and in particular in the early morning. And if they decide to perform physical activity in the afternoon, usually I recommend not later than 6 p.m. Otherwise, the exercise later in the evening could have a negative impact on sleep latency.
So this question is for both Orly and Louisa. So when we talk about a 24-hour movement behavior, a healthy behavior movement cycle over the course of 24 hours, it's already very challenging to try to increase moderate to vigorous intensity physical activity. So now when we layer multiple behaviors on that, what do you see as the barriers and challenges to trying to help patients to change now multiple behaviors versus just single behavior that we've tended to focus on, which is already challenging?
And thank you very much for the question. I think it's currently we don't have evidence what is the best strategy to have an optimal intervention. Is it to start with only one behavior or to start with all behaviors? What I read in literature is probably try to change one first and after to add other component. Maybe start with the behavior that patient prefer to change. It can be an option, but we don't know. That is why we really need more study about what is the best strategy. Is it altogether on only one?
Just to add to that, I think it gives us more of an opportunity to see what, based on a patient's ability, what behaviour we should focus on. Some of the patients I work with, moderate to vigorous physical activity isn't really an option, and it might also give us a different focus at different post-surgical time points as well. So it might be that we can work on reducing sedentary behaviour and breaking up that sitting time to give them the confidence to then be able to increase their moderate to vigorous physical activity. So I think rather than looking at it as a barrier, it's more of an opportunity to provide different physical activity at different time points depending on the individual.
Thank you.
Dr. Herring, I heard that you are not that convinced about the 10,000 steps per day. It's not practice-based evidence, but I wonder from where did the 10,000 steps is a recommendation? Do you know about that? It's better than nothing, but we always advise people to go for the 10,000 steps.
Yes, so the 10,000 steps is obviously based on very little evidence, and the data that I presented there is based on a very large cohort. I can share with you the reference for that. And it just shows that, especially with the under 60s, the 8,000 to 10,000 steps threshold is optimal for steps in terms of all-cause mortality. But anything above the 10,000 steps actually has little additional benefit. So, and I guess for the groups that we're working with, quite often 10,000 steps is unrealistic. And if we're telling someone that's currently walking 2,000 steps a day, you need to be getting to that 10,000 steps threshold, well, they're probably given up before they've even started. So we also know that increasing by 500 steps has clinically important difference, a clinically important benefit, in those individuals. So when we work with individuals, we try and get them up incrementally to that threshold, rather than just saying, this is the guidelines, you need to walk 10,000 steps. But we know now that it's not necessarily 10,000 steps, that threshold's a little bit lower.
Okay, and the brisk walking is better than?
Yes, and that's one of the ways that you can get benefits, and it takes up very little time trying to get people to walk faster.
But it would be difficult for the preoperative surgical obese patients.
So that walking faster in anybody, any of the population, is beneficial.
Yeah. Okay, thank you.
Thank you.
I'd like just complete. Absolutely, this and is important. The recommendation is 10,000 all people, but in this population, 10,000 steps per day is too much, is much. And I think for my patients that you walk one day 10,000, if you walk one day 1,000, because if you don't walk, you never walk at the recommendation. You need to begin. And in one moment, you follow during the day, and you can this objective, this goal.
Maybe I missed some concept from Giovanna's presentation. I was wondering, we are born old, or there's something genetic, or something that is just behavior? Maybe I miss it.
Thank you for your question. Chronotype category is like obesity, so is a sort of multifactorial categories. So we know that there is a genetic predisposition, but also there is the impact of behavior. And there is also usually a hormonal derangement that is characterized by a reduction of the cortisol peak during the morning, and there is a delay in the cortisol peak during the second half of the day. So all these features could contribute to determine evening chronotype.
Thank you. And also, I have a question for Professor Bayot. What about the implementation of your guidelines in Canada, just your experience? What's
It's my experience about implementation. I know that they work a lot with an expert team but what is important is probably the visual first, I'm no experience, and I don't aware if there is now a study that show how the guidelines is known in as providers and population. But I know there is a lot of effort to do that, but probably there is papers that can explain this experience and all the work they did, but I'm not an expert in that, sorry.
Thank you.
Hi, I have a question for Dr. Rejane. I don't know if you have a recommendation for timing after surgery, like post-op, for aerobic exercise and strength exercise. At what time it will be better to introduce aerobic, and what time will be better to introduce strength training?
I don't know if I understand correct, but you ask about strength training, training and aerobic training. I work in hospital before bariatric, all training, strength and aerobic. And after bariatric, it's important begin the strength training, because these patients reduce the mass, the muscle mass, and the strength training is many important. But look, we have, these patients have low adherence, and sometimes it's good you introduce the strength training, for example, but the patients don't like, or don't have condition to pay in the gym for academy, and these patients don't practice exercise, and you need to reduce the barriers to practice exercise. It's important have one protocol, is a good protocol, but have a reality these patients that you need to think. I like when you can associate the two train, aerobic, strength and stretching, and walk all day. And this, we speak in this conference, during the day, your patients walk and change your sedentary behavioral. It's important, this association. And this is education. Mm-hmm. And you can, it's important that teams, the bariatric surgery teams, speak about this, knowledge, the knowledge about this, and it's important public politics that begin this work in the children.
I have experience with aerobic like in the first months, and then when I see that they are almost an overweight on their ideal weight, I start with strength lifting, and they have been really good. But I don't know if there's a protocol of timing to introduce exercise. But
Sorry.
thank you.
Okay. Thank you.
I was just going to add to that, potentially, after bariatric surgery, people's priorities are typically not around the exercise because they see that weight loss and they don't feel like they need to become that active. However, I think there's an area of research that's under-researched looking at the point of weight plateau, and I think exercise could have a big impact there. I'm not saying that individuals after surgery shouldn't become active. Of course, we should promote the lifestyle behaviours, but functional exercise, I think, may make more of a benefit a little bit later on in the post-operative journey.
Sorry, I have a question about chronotype, if it's possible, to Dr. Mascojuri. Do you think that measure of melatonin levels in blood sample can be useful to define the chronotype of a patient or not? What is your experience? And
Okay, so I believe that the measurement of melatonin levels is not useful to define chronotype categories. And this is because the reduction of melatonin levels is just one of the features that determine chronotype categories. So we have other features like hormonal typical patterns, behavioral features that could contribute to determine chronotype categories. So you can have low melatonin levels and you can just have sleep disturbances, but you cannot be even in chronotype.
okay, okay, thank you.
Just a comment. First, I'm Brazilian. I speak Portuguese. Sorry, my English. And so this recommendation is not for just patients. The recommendation for exercise is professional too. Is important. The patients and the professional that work these patients practice exercise too. Okay.
Okay, I think that we can close and thank the speakers and also the public present. Thank you. Have a good